Good day to all of you, and thank you for inviting me to give this talk at this wonderful meeting. I would like to thank the organizers for inviting me specifically for me to cover a topic which is close to my heart. I'll be talking to you about the differential diagnosis of diabetes in the young in India and insights into the mechanisms and the patterns of these diseases. I'll be covering a fair amount in terms of what our original work in Velo is as far as these conditions are concerned. This is indeed the most comprehensive publication when it comes to the epidemiology of diabetes in India. Unfortunately, what it shows is largely what belongs to type 2 diabetes, and from a clear perspective, we do not have information as far as diabetes in the young is concerned in this country in terms of the epidemiology. Nevertheless, let us focus on the classification of diabetes as far as the WHO is concerned. And this slide shows you the 2019 classification, an updated version. We have for you type 1 and type 2 diabetes, of course, as the key and common forms of diabetes. And then we have the new form, the hybrid forms of diabetes, which involve two types. And then the categories, which are the other specific types and unclassified forms at the bottom. So I will not cover type 1 and type 2 diabetes because these are talks which are going to be covered in the next few days. I will go straight to the baseline algorithm as far as we are concerned to help you make a diagnosis. A detailed history is required, a good pedigree chart and a physical examination. The measurement of C-peptide levels should not be understated and in fact plays a very important role from a cost-effective perspective of differentiating the various forms of diabetes. The GAD antibodies are a basic test in the armamentarium, and of course imaging of the abdomen is also required, and I shall show you how it is so vital. The other tests which I've outlined over here are those which actually play a role in terms of quaternary care. These tests may not be possible to be done at the primary or secondary care and may need to be, particularly the genetic testing can be done only in about 3 or 4 centers across the country. So let me focus first on the hybrid forms of diabetes, slowly evolving immune-mediated diabetes of adults. Here is a clinical example, a 29-year-old male with a history of osmotic symptoms and weight loss in 4 months. There is no family history, which is also key to the diagnosis. His body mass index is 20 kg per meter squared. He's underweight. The ketones are negative, and the glycemic control was easy in the first 1 year with oral antidiabetic agents. He required insulin thereafter. So on testing, he was found to be GAD antibody positive. His C-peptide levels were extremely low, and his imaging of the abdomen did not show a shrunken pancreas or any calcification. So the type of diabetes over here that we are dealing with, because it is immune-mediated, this is a slowly evolving immune-mediated diabetes of adults, formerly called LADA, generally seen above the age of 35 years. Having said that, this comes into the bucket wherein it is not a typical type 1 diabetes. The autoimmune islet cell markers are positive, and the therapy requires insulin, and generally basal bolus insulin works much better. I shall go next to the second form of hybrid diabetes, or to the ketone-prone type 2 diabetes. This is largely reported from populations across Africa, African American populations in the United States, and Chinese populations. Until more recently was not reported commonly from South Asia. These patients have unprovoked ketoacidosis, are generally more than 30 years of age. Having said that, in India, they could be younger. The autoantibodies are negative, and they have an explosive onset with a high insulin requirement. The rapid reduction of insulin requirement is seen within about 3 months. None of them will require insulin, and they can be maintained with oral antidiabetic agents and even dietary control in a subset of patients. First described in Brooklyn in New York and in a suburb known as Flatbush, and therefore called Flatbush diabetes. So we first reported a large cohort in the year 2017, and this was the first large cohort from South Asia, which showed very clearly that this entity existed in South India. And what was the defining feature was that the C-peptide levels at baseline were extremely low with diabetic ketoacidosis, but within a period of about 3 to 4 months, the C-peptide levels, particularly in the postprandial phase, showed a rise. And you can see over here that we had two groups, a group which had ketoacidosis with GAD antibody positive and the ones without GAD antibody positivity. And essentially, those patients without GAD antibody positivity, in fact, had a remission and were able to be controlled with just oral antidiabetic agents at the end of 3 months also. Insulin was discontinued in all those patients who were GAD antibody negative. The baseline characteristics that they tended to be overweight, more common in males, and there was a strong family history of type 2 diabetes in addition. So this condition exists in India, and we need to think about it in our younger patients who have diabetes which appears to be like type 1 in the initial phase. Let me turn to the other forms of diabetes, which include the monogenic forms. And of course, for this particular audience, you're all extremely familiar with the monogenic forms, but I shall give you a little bit a perspective from an Indian viewpoint. You can see over here MODY, classically thought to be an age of onset less than 25 years, 3-generation family history with siblings involvement, and generally non-insulin requirement. They are thought to be monogenic and are usually associated with a non-obese state. If you look at the latest WHO classification, all 14 types are not cited over here. And the reason for this is that it has largely been found that these patients are thought to be not typically MODY in a certain subgroup. For example, certain types like the Neuro D1, which have been reported previously as MODY, do not fulfill the full criteria when it comes to looking at pathogenic variants. Having said that, we could go either way in two groups, one which are certainly the monogenic forms and which the WHO classification now fits in, the GCK or MODY type 2, the HNF1 alpha MODY type 3, HNF4 alpha type 1, and the mitochondrial forms have also been put under the basket of young onset diabetes in addition. These are the common forms which have been reported, and we have also reported Wolfram's and MODY 12 or ABCC8 mutations in our young adult population with MODY. So this was our publication which came out in the year 2014, which gave a slightly different perspective. It was the first NGS-based publication from India at that point of time. And we tried to answer these questions which I had initially posed to you. So here are some classical cases. Note the extremely intense pedigree chart, which is so important to be drawn when you're trying to make a diagnosis in these patients. Also, in addition, please see the patient over here with the intense presentation from the male side of the family. The glucokinase mutation is positive over here, and it's MODY 2. The next patient over here who presents with evidence of MODY 5, renal cysts in addition, as you can see over here. And this is a spreadsheet of our initial patients who presented over here, who basically presented with different forms. And you can see the commonality of MODY 6, the Neuro D1 mutations over here. So the Neuro D1 mutations which were more common, and MODY 12 with the ABCC8, which is also more common in our adult population. So besides this, of course, we had the full spread of 14 mutations present in our adult population. What I would also like to highlight over here in this population is that there were a number of patients who were obese at presentation with the typical pedigree chart, and there were patients at the other end of the spectrum who were lean with low BMIs in addition. So let me recap and say MODY 6, MODY 4, and MODY 13 were the common forms in our series. Over here we show a patient with a diagenic mutation. You can see on the maternal side, we have MODY12, ABCC8, and a PAX4 mutation on the paternal side. And the child, the index case, who's a boy, has both mutations and has more severe diabetes. So there's a dose effect. Insulin requirement in the child, whereas both the parents required only oral anti-diabetic agents, even though they had a relatively young onset at presentation. And we have reported more multigenic or polygenic presentations for MODY in addition in our series. We have also looked at young pregnant women who were in their first trimester, who had BMIs ranging from 19 to 21. And those of us who treated these patients, the ones with the more severe disease with insulin, were screened in this particular study, which was published in PLOS ONE. And we have therefore identified that almost 18% of patients who presented with insulin requirement in the first trimester had in fact MODY. And in fact, their initial presentation was not before they became pregnant. It was when they became pregnant, they were screened and they were found to have hyperglycemia, and we identified these mutations. So it should be thought about in these young ladies in particular. So let me summarize. MODY is seen in about 30% of our patients over here. In those who have young diabetes, these are the common forms. A large volume of these patients are picked up in adulthood, some being clearly missed in childhood. Pregnant women with diabetes and an autosomal history have MODY. MODY could also be diagenic in origin. And we have a single window 40 gene panel for young diabetes using NGS, which can be cost effectively used for diagnosing young onset diabetes and MODY. The next patient is a 28-year-old with lean diabetes for 15 years. In fact, I thought she probably had pancreatic diabetes because she had evidence of a shrunken pancreas and calcification. But then her daughter presented to the pediatric neurologist with exquisite myopathy and weakness. And this was notified to me. So we put two and two together and we did NGS looking for the degree of heteroplasmy in our patients. And we found indeed that the mother and the daughter had the same mitochondrial mutation. And heteroplasmy, which is minimal or milder, may not be picked up with Sanger sequencing. Therefore, the advantage of NGS for diagnosing mitochondrial mutations may be better and may be picked up at a much earlier point of time. The patient over here had a muscle biopsy which shows evidence of ragged red fibers on the Gomori stain. And of course, mitochondrial myopathy may be the most common presentation amongst mitochondrial disorders. Other members who have diabetes in the family should be thought and should be screened for a mitochondrial disorder as well. So we know that patients with mitochondrial diabetes may have siblings who may have presentations which may be totally different. Some with deafness, some with macular dystrophy. Patients could have been present with focal segmental glomerulosclerosis, with renal failure, and of course the classical presentation of MELAS with strokes and myopathy, of course, in addition. The other forms also include those with insulin resistance. And once again, the WHO classification has the common forms of insulin resistance. You as pediatricians are familiar with type A insulin resistance, leprechaunism, and Rhabdal-Mendenhall syndrome in particular. Here are a few examples of what we have seen when it came to insulin resistance. An 18-year-old female with diabetes detected at the age of 15 years on premixed insulin. And like any other young lady, she was frustrated at the age of 16. And because of her control being difficult, she stopped her insulin for 4 to 5 days. But she never ever went into ketoacidosis when she stopped her insulin. She had hypertriglyceridemia from the age of 15 years. And her mother too had diabetes in addition. So you can see over here the profile of the mother and the daughter. They have elevated C-peptide levels, and the HOMA-IR, which is a measurement of insulin resistance, was also exquisitely elevated, particularly in the mother. And the daughter had hypertriglyceridemia. The mother was already on treatment. This is the body composition, as you can see, which is done using a DEXA scan. And the upper part of the body, that's in the arms and in the head in particular, has an increased amount of fat distributed over there. Almost 20% of the body fat is in the region of the head, which is rather unusual. She was not otherwise grossly obese. Neither of them were grossly obese. And you can see this is basically a partial lipodystrophy, a Dunnigan variety. And once again, we did NGS and picked up the mutation for the laminin gene, which is classical for familial partial lipodystrophy. Over here, we have another young lady who's come with stunting of growth and is extremely emaciated. She also has almost a total lack of subcutaneous fat, and the mutation screening has been done here, the AGPAT2, which shows evidence of generalized lipodystrophy, which is classical for the Bernardelli-Seep syndrome. The other genetic syndromes as well can be screened with NGS, next generation sequencing. We can see over here a young lady who came with hyperglycemia, hyperpigmentation, hypertrichosis, hypothyroidism, and short stature. When we thought about short stature and diabetes, we thought perhaps because of the amenorrhea, this may be even Turner syndrome, but the FSH was not classically elevated. And she also had negative GAD antibodies with low C-peptide. So she was insulinopenic with diabetes, but she had in addition hearing loss and cardiac involvement with the bicuspid aortic valve. So essentially we did a genetic screening because of this pigmentation, and she was diagnosed to have the H syndrome, where the classical mutation of the SLC29A3 gene was present in both her as well as a heterozygote in her mother. We come next to the disorders of the endocrine pancreas, and I would like to cover fibrocalcific pancreatic diabetes next on the list, classically presenting with abdominal pain in the first decade of life, maldigestion or steatorrhea in the second decade, and uncontrolled glucose levels in the third decade above the age of 20 years. So this is a condition wherein imaging is critical. They usually have a shrunken pancreas with duct dilatation and exquisite calcification intraductally, as you can see here on the CT scans. And the C-peptide levels are low. It is classically described only in tropical regions. So obviously there is an environmental genetic interaction which we know very little about. The environmental factors have been postulated, but many of them has been dismissed in more recent times, and we still are unaware of what it might be. The initial presentation is that of the tropical pancreatitis with malabsorption by the second decade, but by the time they reach their 20s, they have diabetes. And you can see over here that we have controls which are normals, and the blue line over here shows exquisite insulin deficiency. The tropical pancreatitis has this last gasp surge of insulin levels. Therefore, the area under the curve is greater than that of the normals. Most interesting was the response to indirect calorimetry. We did energy expenditure studies in these patients, and we found that those patients with pancreatic diabetes had a much higher energy expenditure than what was expected for their BMI. And this was in spite of the fact of correcting their glycemic control as well as giving additional enzyme supplements to correct the fat malabsorption. The third feature, which is classical of patients with pancreatic diabetes, is this paradoxical glucagon elevation. One would expect with gross fibrosis of the pancreas that both the beta as well as the alpha cells would be destroyed. But over here, what we found was this profound increase in glucagon levels. It is seen in the phase of tropical pancreatitis before they develop diabetes, and it becomes gross once they develop fibrocalcific pancreatic diabetes, and the glucagon levels are grossly elevated. What could be the reason for this? Now there are two possibilities, either that the alpha cells are still functioning, for which we need to of course take post-mortem samples and look at the alpha cells and immunostain them for glucagon, or could there be another source? Now what has been seen is that in pancreatomized dogs, the glucagon levels are paradoxically elevated. So it could be happening that the glucagon is coming from a pro-glucagon genome which exists in the L cells of the intestine which normally produce GLP-1. Perhaps. So you can see over here that the pancreatic polypeptide levels are low, which is parallel to that of a non-functional pancreas. The P cells are also not functioning. That's the blue line at the bottom over here in patients who have fibrocalcific pancreatitis. And the controls who have a normal pancreatic polypeptides. The GLP-1 response is normal, which means the L cells are functioning normally over here. A good GLP-1 response to glucose, oral glucose, and the oxyntomodulin levels are also, as you can see over here, elevated. So it indicates that the L cells are still functioning. So there is this every possibility that the glucagon levels which are being seen may be coming from the L cells. We haven't proven that yet, and it will need further investigation. So these patients are insulinopenic, they have profound glucagon production, and the glucagon may be of L cell origin considering the concomitant rise in GLP-1 and oxyntomodulin levels. They need low dose insulin therapy, they are more prone for hypoglycemia, and they need enzyme supplements containing lipase. It is mandated, and you need to give them extra calories, correct the glucose, give the lipase, and at the same time make sure they take an oral intake of more than 40% what is expected, and some of them end up taking 2,500 to 3,000 calories of food per day to help them build up their muscle mass and improve their body weight. They have a high propensity for pancreatic cancer as well, almost 40% if they cross the age of 40. Finally, let me come to this intriguing form of diabetes, the unclassified form in our Indian population, what was initially called malnutrition-modulated or protein-deficient diabetes mellitus. It was included in the WHO classification till the year 1996, and then it was unceremoniously dismissed. People in the West said it did not exist, but it still does. Let me tell you, in rural areas, impoverished parts of the country, it is still very much a problem. So the international prevalence of undernutrition, sadly so, in spite of the obesity which is there, we still have a double burden of undernutrition in our country. As you can see, the yellow on the map, ranging from 15 to 24% of the population. And thereafter, when we study these populations, you see that there is a prevalence of diabetes amongst all the diabetes, maybe around 1 to 5%, which has these peculiar characteristics. Glucose levels more than 200 at the fasting state, onset of diabetes below the age of 30, but above the age of 15 or 20, generally speaking, absence of ketoacidosis on withdrawal of insulin. They all come from a poor background. They need relatively higher doses of insulin, up to 60 units per day, and they are of rural origin. And when you do an imaging of the pancreas, there is no evidence of calcification or duct dilatation. So our study has actually shown that 5% of the rural Tamil Nadu population with diabetes and 1% of the urban population have this particular condition. What is it due to? Now, it's not clear exactly what, but it has been shown that malnutrition in lab animals can cause a decline in insulin, glucagon, amino acids, and other insulin-trophic stimuli. Ish Bhatia has shown in his studies that the phase of hyperinsulinemia and subclinical malnutrition, which then subsequently deteriorates to hypoinsulinemia, is correlated with underfeeding. And we in our studies have shown that this condition is not related to the Barker hypothesis, which is a prenatal phenomenon, wherein undernutrition intranatally ultimately leads to subsequent weight gain and obesity as they become full-grown adults. And that is more the type 2 diabetes phenotype. And by and large, the diabetes over there has its onset beyond the age of 30 or 35. So it's not that condition. It is separate and related to postnatal malnutrition. So over here we see the physiological characteristics of these patients. First, they are lean and they also have evidence of low insulin levels. So you can see over here the lean subjects have low insulin levels, the blue line. Type 1 is the red line at the bottom, and these are patients with type 2 with hyperinsulinemia in the initial phase. We have also studied their body composition using NMR spectroscopy, looking at the micro quantities of the fat in the muscle, in the liver, in the abdomen, and also in the pancreas. And what we have shown is that the NMR spectroscopy show that visceral fat is abnormally high for a low BMI. These are lean normals with BMIs of less than 19. These are type 1, which also have low intra-abdominal fat. But the malnutrition-modulated diabetes have visceral fat, which is more than them, but not as high as type 2 diabetes. However, what is most striking is the NMR SPECT quantification of fat in the pancreas. And you can see over here that malnutrition-modulated diabetes has very high pancreatic fat content. Now, whether this is an epiphenomena or is responsible for the beta cell dysfunction, is it a kind of lipotoxicity for the beta cells, we do not know. And you can see clearly over here that even type 2 diabetes, though it has an increase in pancreatic fat, is not as high as that of malnutrition modulated diabetes. So let me summarize the pathophysiology of malnutrition modulated diabetes. They have a significant insulin deficiency, much lower hepatocellular fat than type 2 diabetes, low visceral fat content, and exceedingly high pancreatic fat content, unlike any previous condition reported. Physiologically, they are a unique form of diabetes. It is not a lean variant of type 2, mind you. I've shown you physiologically it is different, and they require insulin, whereas type 2 diabetes can be well managed with oral anti-diabetic agents in the initial phases. So diabetes in the young, the Indian subcontinent, what does it mean? You should think about these conditions, especially when you're thinking of lean people. Fibrocalcific pancreatic diabetes on the top of the list, maturity onset diabetes of the young, ketosis prone diabetes, lipodystrophy, mitochondrial diabetes, which I've talked about. I have not talked about HIV lipodystrophy, that occurs in a slightly older subgroup, but patients on highly active antiretroviral therapy can develop lipodystrophy and develop diabetes which is insulin resistant. So these are the forms which would be commoner in the younger population. And I have just put this together with age cutoffs, FCPD in an age of onset 20 to 35 years, MODY 6 to 35 years, ketosis prone diabetes 25 to 40 years, type 2 10 to 30 years when it's young onset, and the C-peptide levels may be good markers, low in FCPD, low intermediate in MODY. In ketosis prone diabetes, low at diagnosis, normal later on, elevated markedly in lipodystrophy, intermediate in the mitochondrial disorders, syndromic forms depending on what syndrome you're discussing, it's variable, elevated mild to moderate in HIV lipodystrophy, elevated mildly in type 2 diabetes in the initial phases, and low in undifferentiated lean diabetes, that is your protein deficient form of diabetes. Pancreatic imaging is critical, and so also GAD antibodies when you're not sure of your diagnosis, because we found these patients who came to our clinic, they were previously evaluated at other centers and they did not have these two tests done and were on insulin or oral anti-diabetic agents, poorly controlled, lean people. But we found that a large number of them were GAD antibody positive and the remaining ones had calcification in the pancreas which clinched the diagnosis. So these are the common types. Your baseline algorithm, once again I'm highlighting, the basic tests which can be done at a primary or secondary care center, and of course next generation sequencing is crucial, revamped along with accessory Sanger sequencing and multiple ligand probe dependent amplification for patients who have deletions or insertions which may not be picked up by next generation sequencing. So I'd like to thank my whole team, a very large list of doctors, outreach group, biostatisticians, the lab, the dietitians, the NMR spec nuclear physicists, and a number of residents who have worked with me, and the metabolic nurses who do all our dynamic testing, including the CLAMP studies. So, like to acknowledge our multiple funding agencies and international collaborators who have also helped. Thank you very much for your patient listening, and I'd be very happy to answer your questions which you pose for me.